questions in
I
between?
don't know. What do you?
Maybe like one,
Maybe
one or two,
if there's a
and then
burning one,
yeah,
or
yeah. It's sometimes nice to get something happening in the moment.
yeah. Well, we're gonna like a chair for the question period, no?
Sorry.
Because if like Mathieu, Marie-Ève, like for our discussion at the end, well, we're just gonna bring a chair and
Yeah, for sure. Let's just bring a chair over.
yeah. Okay. Are you going to use the podium to introduce, or?
No, I'm gonna sit
I
right
might
here.
just move over there and
Yeah.
once you're
À la fin, tu sais, il va manquer des chaises. Il va manquer une chaise pour la période de questions. Fait que si tu veux juste en prendre une puis l'amener. Je sais pas, ouais. En tout cas,
And we can, people could stand over at the podium as well, hey?
we leave Mathieu on the podium and
Yeah, there you go.
okay.
Yeah. Yeah.
Just faut qu'on we have to
So you could even have Matthew
Mathieu
and
you
Alex
come.
over there or something.
Yeah.
Yeah.
Ouais,
Yeah.
c'est ça. Okay.
I'm sure they'll have lots of questions for him.
I hope. Yeah.
Yeah, definitely. And yeah, I think so.
Oh, we're late. Yeah, maybe we should start. Yeah.
Are we ready to start? Yeah? Are we ready to start? Is it time? Is everyone ready? Are you still awake? Yes? Hello. Hello. How is your jet lag doing? Yes? Wonderful. So I'm Marian Selfridge, and I am delighted to be co-chairing this panel that is called Moving Forward Towards Broader Implementation of Safer Supply. We have some wonderful people that are going to be speaking from a variety of different backgrounds and places of expertise. Did you want to say anything?
Yeah, hi, and my name is Anne-Sophie Tomre-Carrière. I'm a physician doctor in Montreal, Quebec, and I will co-chair that session.
So, without further ado, we want to get started with Dr. Sereda. Dr. Sereda, is that the best way to pronounce your name?
Sereda, but close enough.
Sereda, yeah. The founding physician of the Safer Opioid Supply, the SOS, which provides pharmaceutical-grade opioids to people dependent on the unregulated street fentanyl supply. Dr. Sereda's practice focuses on caring for people who use drugs, people deprived of housing, women in the survival sex trade, as well as medical street outreach and care in non-traditional settings, such as shelter or jail. And Dr. Sereda is an avid harm reductionist, practicing solidarity with all marginalized peoples, with the goal of eliminating power structures in medicine that perpetuate poor health and oppression. Thank you.
You make me sound so well-rounded there.
The godmother.
So thank you. I'm Andrea Sereda, as Marianne introduced me, and we are so pleased to be here at INHSU presenting Safer Supply to everyone who's here today. It's my first time at INHSU, and I'm having a great time, so I hope everybody else is as well. We cannot actually begin to cover everything that we want to tell you about Safe Supply in this presentation. So I'd like to call your attention to my colleague Alex, who is going to distribute a handout with some QR codes on it that link to some of our key documents on the Safer Supply Community of Practice website. And we will be linking to that in Alex's presentation as well. And if there are questions that we don't answer today, I'm easy to find on Twitter. My handle is my name, and my email is in the conference program. I've received funding from Health Canada, from the SUAP granting organization, to run the program I'm going to describe to you today, but I have received no money or sandwiches or anything else from Purdue, which are the manufacturers of Dilaudid. So the Safer Supply program in London, Ontario is the first and longest running Safer Supply program in Canada. We currently have about 300 people on Safer Supply in London, and we're actually tirelessly working to take hundreds more in. And the work started in London in 2016 out of really a desperate attempt to keep people alive at that time. We were at our wits' end. I was at my wits' end as a doctor. Fentanyl had been on the streets of London, Ontario, again in Canada, not London, England, for 2 years, and people were dying. And really, none of the traditional addiction medicine interventions that I had available to me at the time as a physician were helping. And I really personally felt powerless to take care of the people I was serving. And so Safe Supply, it emerged in 2016 out of that desperation as a harm reduction intervention meant to keep people who are at the highest risk of death alive. And you know, we were successful at death prevention in those early years. And as the program became longer, we started feeling like what felt to us at the time like magical improvements in people's health and their well-being. And I'm going to review some of those results and research today with you today. So I know fentanyl is still a rare thing here in Europe, and this is a really good thing. It means you have time. Coming to Scotland, I was really trying to rack my brain to really impress on the INHSU audience and try to figure out how to tell you what's coming and how to warn you about how to get ahead of this death epidemic that we've been facing in Canada and North America from fentanyl. But you really do need to get ahead of this, and I hope I'm going to show you why. I only have 15 minutes to tell you why, but I really do hope I can give you a sense of urgency. So we hear a lot about fentanyl in the media, and I'm going to unpack this a little bit to help you understand why people are dying by the thousands, by the tens of thousands, by the hundreds of thousands in North America, and really show you why Safer Supply programs are so critical and why are they critical before fentanyl comes. So you can see here that fatal overdose rates have been increasing by double digits in Canada for every year that we have been measuring. And we hear a lot about the downtown east side in British Columbia and Vancouver being the epicenter of the solutions to this, and we hear about a lot of their solutions. But Ontario, the province where I am in Canada, it actually had the dubious distinction of surpassing BC and Vancouver death rates per capita in 2019, and it's only gone up since then. And it's really the rural, the remote, the northern communities of Canada that are currently disproportionately experiencing these death rates. And so the solutions that we've developed in Ontario do look different than the solutions coming out of Vancouver. Why have all of these Canadians died? The enormous mortality that we're seeing from among people who use the street opioid supply is due to the replacement of the street drug supply by fentanyl. We hear a lot in the news about street drugs being tainted with fentanyl, and that was maybe true in the early years of this crisis in 2014 and 2015, but the street supply of opioids in North America is no longer tainted by fentanyl, it is fentanyl. And so currently, more than 90% of the opioid overdose deaths in Canada are caused by street fentanyl. Why is fentanyl disproportionately killing people? And some people who may have come to my colleague's presentation this morning saw this slide. It's actually not fentanyl killing people. We use fentanyl safely in emergency rooms and ICUs, hospitals across the world, around the world. If you have had a surgery or a broken arm or admitted to the ICU, you have received IV fentanyl and you are still here alive today. But what is killing people is the volatility, the unpredictability of the unregulated street fentanyl supply. Because street fentanyl is not a uniform product. It contains many different analogs of fentanyl, which are all represented by different colored lines on this slide. They all have their own distinct potencies, and this slide really shows the shifting volatility of that supply. All fentanyl analogs are different in their strength, like I said, and so day to day and week to week, people really have no idea the strength of the drugs that they're consuming. And I educate my patients by telling them it's like a batch of chocolate chip cookie dough. If you don't mix your cookie dough well enough, you can end up with a cookie that has 20 chocolate chips, or you can have a cookie that has 2 chocolate chips. These cookies are both from the same batch, but they have wildly different chocolate potencies, and fentanyl is the same. Now here, You can see 5 samples from a batch of fentanyl that was moving through Ontario in the spring. And this was a particularly bad batch, and it was killing people at a very high rate. And when we tested this sample, we found that part of this batch was 77% fentanyl. And for reference, the provincial average is 4% fentanyl in a sample. So the next 4 results that you see here, they are from the same batch. And the amount of fentanyl in here is 0 to 17 to 28% fentanyl. And these are all coming from the same batch of fentanyl, no bigger than the nail on your pinky finger. And so this is the chocolate chip cookie effect in action, and this is why people are dying. So we have seen the same type of deaths during American alcohol prohibition in the 1920s. And this is a time when people, they might again end up drinking a wide variety of potency of alcohol. It was 11% or maybe it was 80%. And sometimes on this alcohol you got a pleasant buzz and sometimes you went blind and you really didn't know which was going to happen. The Liquor Control Board in Canada, it solved this problem. You can now walk into a store and you can buy alcohol at a known concentration. This does not mean that you won't drink too much and get in a car accident or fall down and bump your head or, after 30 years die of liver cirrhosis from your drinking. But it does mean that the government regulates the concentration and quality of your alcohol and you will not die from accidental alcohol poisoning. So I always ask, why do we regulate drugs like alcohol and make them safe for people who consume them, but we're unwilling to do the same for opioid users? And the joke I usually use here as well is if you want to actually debate the impacts of prohibition with me over a safe beer and a supervised alcohol consumption site, I will meet you at the bar after. So, using the wrong, I need to go back. My apologies. So beyond overdose, it's jumping around here. Fentanyl is also driving an increase in infections of all types among people who use drugs. So this is a study conducted over 7 years showing the rate of serious infections growing significantly with a sharp inflection in 2015 when fentanyl hit the scene. You can see a 167% increase in endocarditis, 394% increase in spinal infections, 191% increase in bone, 150% increase in skin or soft tissue, all dramatically increasing when fentanyl started to dominate our streets. And a sharp increase in people's opioid tolerance due to fentanyl is also affecting our patient outcomes. So fentanyl is measured in points, which is 1/10 of a gram. And larger volumes are measured in grams or balls. So a gram is 10 points, a ball is 35 points or 3.5 grams. And when we started the Safer Supply program in London in 2016, most people were measuring their use at 1 to 5 points per day. And now, since 2020, most of my patients are measuring their use in 1 gram to half a ball. So community tolerance levels have really skyrocketed. And why does this matter? I'm going to show you some math. So 1 point of fentanyl can be converted to 440 morphine equivalents, or MEQ, M-E-Q. So this means if you took 1 point of fentanyl, that's the same as you taking 440 milligrams of morphine. If the average daily street use is 5 to 20 points, that is 2,200 to 8,800 milligrams of morphine per day per person of unregulated street fentanyl. And to put this in perspective, that's equivalent to methadone, 2,900 milligrams, hydromorphone, 1,700 milligrams, or oxycosets of 160 to 650 per day, tablets per day per person. So can we please all pause and have a collective what the fuck at these numbers? Because this is what has rendered our conventional treatments unhelpful, and that's to put it mildly. This right here is why Europe needs to get ahead and institute safer supply now before fentanyl dominates your drug market, while you still have a chance to actually catch people's opioid tolerances. So what is safer supply? It's part of the solution. We do not consider safer supply to be addiction treatment because we don't believe that most people who use drugs need to be patients or need a medical intervention. What most people just need access to is a drug that won't kill them. And so we don't place any expectations of weaning or abstinence or conversion to OAT on people. We let people choose what works for them in their own lives. And we also don't believe that safer supply is the only or best option for everyone using the unregulated street supply. The goal for safe supply is simply to convert people who are using a street supply of fentanyl to a prescribed alternative opioid of known dose and known purity. So in the London, Ontario program, people receive short-acting opioids in the form of dilaudid 8 milligram tablets, which they then take home, crush, and inject. I don't have time to tell you why we chose the dilaudid 8 milligram tablets, which we call D8s in Canada, but I'd be happy to discuss this in questions or after the session. And then along with people's short-acting D8 tablets, most people get what we call a backbone of a longer-acting opioid such as Cadian or MS-Lon, which are longer-acting morphine preparations in Canada, or increasingly methadone, and increasingly 2 long-acting drugs for backbone. And this has come along with the increased tolerances we see in Canada because we just cannot keep up with people's needs with dilaudid alone. The first set of data I'm going to show you is from our internal program evaluation released just this year. So first of all, safer supply has an excellent retention rate at 94%. And this can be compared to Ontario methadone retention rates, which are at best 40 to 50% at 6 months. And this ability to retain people in safe supply is really critical to pulling them away from that street supply because we're giving people an option to move away from fentanyl even if they don't want to stop injecting drugs. And although we firmly operate safe supply as a harm reduction program, prioritizing human rights and autonomy above all else, we are actually seeing really robust results in terms of improvement in health and well-being. Here, we can see that 63% of our patients report that their fentanyl use has decreased since starting safer supply. And this is a finding that surprised even us. So I want you to remember that every person receiving a safer supply had the intention of continuing to inject drugs, but in a safer way. And yet, all on their own, 35% of our participants stop injecting drugs altogether. We've also seen a dramatic reduction in non-fatal reversed overdoses. You can see here we've dropped non-fatal overdoses in 6 months from 59 to 23%, and overdoses in the last month from 33 to 11%. We have reduced emergency department use in the people we serve from 77 to 45%, and hospital admissions from 36 to 11%. 59% of our patients say their physical health has improved since starting safer supply. And 53% of folks say their mental health has improved. Then beyond health outcomes, we have also seen a decrease in engagement in criminalized survival activities like petty crime. Here you can see that 86% of our patients were engaged in criminalized survival crime before coming into the program, but that went down to 44% stopping all activities and a further 47% saying they have reduced. We have also seen reductions in the number of women performing sex work. And again, this is because they just don't need to work to make the hundreds of dollars a day needed to support their fentanyl use. And so a point of fentanyl on Ontario streets currently costs between $20 or $40 a point. And again, if you're using 10 to 20 points, you can really do the math on behalf of these women. Again, sex work can range from $10 for oral sex to $60 to $80 on the street for other services. So again, you can do the math on behalf of these women. So I firmly and loudly need to see here that sex work is real work, and we don't try to stop any woman who wants to engage sex work from doing so. That is her choice. But I think we actually give women more choice in their sex work by being able to do it at a pace that they decide. So this woman says, "We don't have to go to the streets anymore to make our habit, to make money to pay for our pills. Since I've been on the program, I have not gone to jail in 3.5 years. That's a good thing. I'm pretty much not working in sex work at all anymore, so it really saved my life. And I just have a couple more research slides to share with you before I wrap up. We were so proud to publish this study in CMAJ just exactly 1 month ago on September the 19th. We used health admin data to look at the impact of safe supply on service use and health care costs in London, Ontario. And when we compared people's health service utilization between the year prior to them being on safe supply with the year following program entry, we saw that emergency department visits, hospital admissions, admissions for infections related to injection drug use, all dramatically decreased, approximately 50% in every single category we looked at. And again, in contrast, among unexposed individuals for safe supply, there was no change observed in any of these outcomes. We also saw overall healthcare costs decline significantly among safer opioid supply clients in the same time period, again, reducing about 50%. We also showed no increase in opioid-related deaths among safe supply patients and no increase in all-cause mortality. So while additional research is needed to complete our understanding of the benefits and potential risks, we really think that our findings provide really preliminary reassurance on the effectiveness and safety of safer supply. So this is my last slide. Before I finish, I do want to leave you with a quote of a dear friend of mine who uses drugs and a little bit of a rant. So my friend says, what if, instead of talking about hard-to-reach patients, we flip that around and talk about hard-to-reach doctors, or hard-to-reach services, or services with dumb barriers or restrictions on access, or a system with shitty attitudes? Our community really needs to center our patients when we are designing programs and need to stop centering our own agencies, our own comfort, the conventional morality of medicine. In our community, we need to continue to keep SICs for people who use drugs. We need to continue using traditional harm reduction interventions like naloxone or safe injection sites. But we also need to take really, really large steps to get ahead of this crisis and to start responding before someone has actually stopped breathing, which is where all of our interventions lie right now. Everything that we take for granted in harm reduction right now was once illegal, and drug users have borne the burden, not just of surviving these problems, but of creating and implementing the life-saving solutions that the rest of Canada and the world have really lagged in understanding. I want you to remember that needle exchange, it was illegal in the 1980s when people were trying to save their friends from HIV. And safe injection sites are becoming fairly common in Canada, but they were also illegal until 2008. Up until then, drug users were doing it in their own basements, in alleyways to save their friends, and that was illegal. Naloxone is on every street corner in Canada these days, but harm reductions had to beg and borrow and sometimes steal naloxone before the government decided to fund it. Gold standard treatments for opioid use disorder, like methadone and buprenorphine, are still highly regulated and stigmatized and sometimes quasi-illegal in America, our southern neighbors. So it has taken healthcare professionals and politicians years and sometimes decades to enact what drug users have been doing illegally for years. And when doctors and government, when we adopt these solutions, we like to call it our own ideas. So I really need to nod to the drug user activists with us today at INHSU, because safe supply has been on all of their lips for decades as well. Just like every other harm reduction intervention I've described, in which physicians and the medical community are now claiming, drug users knew what would save their lives first. So the successes of safe supply, they demonstrate to us that for so many people, many of the most grievous harms of criminalized drug use are actually harms that we impose by the system and the state. And again, we need to stay ahead of this fentanyl crisis instead of always being 10 steps, or in Canada, 10,000s of bodies behind. Safe supply is about more than prescribing drugs. It's about building relationships with people who have been pushed to the margins. It's about ensuring medical professionals actually provide comprehensive care to people who use drugs. And it's about pushing our governments to recognize and rescind the laws that criminalize these humans. So thank you for coming to listen to us today. I will turn the floor over to my colleagues.
your presentation, Andrea. We're going to all question until the end, and I will introduce our next speaker, who is Alexandra Oldham. So, based in Tiohtià:ke, colonially known as Montreal, Quebec, Alexandra is a recent graduate of the Master of Social Work program at McGill University. As a current staff member of the Canadian Association of People Who Use Drugs, CAPUD, she works as a knowledge mobilization expert for the National Safer Supply Committee of Practice, NSSCOPE. As a drug user, she is passionate about harm reduction, drug policy, safe supply, decriminalization, and abolition.
Thanks. I'm just going to wait until my slides get up.
Of course. This slide, we're just after Andrea's slides.
Another solution, Marie-Ève, if you want to go ahead, and then I can work that out with them. Tu préfères ça? Okay. See you later.
So we're going to go with you instead? Wonderful. Let me introduce Marie-Ève. Dr. Goyer is a general practitioner with a master's in public health. She's the medical chief of the Addiction and Homelessness Continuum of Services in downtown Montreal. She's a safer supply and injectable opioid agonist prescriber in a low-threshold opioid agonist treatment program in Montreal, and the scientific director of ESCODI, a clinical and organizational support team in addiction and homelessness care, a co-researcher for the Canadian Research Initiative on Substance Misuse, and the scientific lead of Quebec INSPQ training on opioid addiction treatment and medical referent for the Ministry of Health. You sound very busy. And I'm really glad that you came here to speak to us. I'm really excited to hear the perspective of prescribers as well, and the difficulties in terms of trying to figure out how to do this in a good way, hey?
Yeah. Thank you so much. So, hi everybody, very happy to be here. Yeah, everything is fine, nice. So my presentation was the blue one. Thank you. So as you heard, I'm a general practitioner and a safer supply prescriber in downtown Montreal. Before I start, you have to know that in Quebec, most of the safer supply is prescribed to OAT clinic. That's important because that's raising a lot of questions of ethical issues. And also I was asked today not to talk too much about clinics, since Andrea did a very good job, but really to get you to know about the ethical question we've been facing as a team, and hopefully that helps you implement within your teams. I should say, again, what Andrea just did. If you were not touched by fentanyl yet, please implement safer supply now. When we visited Ontario 4 years ago, everybody was saying, oh, you know, Quebec is spare, we're okay in Quebec, nothing is going to be wrong. And our Ontario colleagues just said, hurry up before fentanyl hits you. And we're late now, and we're having trouble catching the train. So I have no conflict of interest. And just to talk about our team, we created a team a couple of years ago that is trying to help clinicians and people who design services for homelessness and addiction with tools, knowledge translation. But also we've been doing a lot to try to help implement this emerging practice in Quebec. So we've created a lot of tools. We've written the first COVID guidelines for safer supply, mostly based on the risk mitigation guide from BC. But this also to give you an idea of the tools you could have when you want to start this new practice. So we have put together papers for our pharmacists to get to understand what we were doing, also explanatory form for our user in order for them to know. But also we've been meeting monthly with prescribers and clinicians and teams so that we can share our practice, our question, and people with lived experience are coming to these groups so they can also put their opinion. And this would be my suggestion to you. When you have people with lived experience who come to talk to prescribers, that's changing completely how we're working. We did a first survey with our Montreal Public Health. This is really our first, so you see we have only 36 prescriber and pharmacists there, but still it's giving you an idea. Our practice is very similar to Ontario's in the sense that most of our safer supply is hydromorphone, short-acting, 8 milligram tablets, and you see that the mean average dose would be 50 milligram, which is quite low if you compare to the mill equivalent of morphine that were described by Andrea, and the maximum would be around 100, but which is for a regular GP, like he's already having a seizure on the floor when you're asking him to prescribe that. I also want to highlight the potential issues that were raised by all the Quebec prescribers. People were scared, or what happened about diversion? What happened if patients sell their safe supply to obtain another substance that we are not ready to prescribe? What do we do with escalating dose? Up to where are we willing to prescribe with the milligrams that you've seen before? And to tell the truth, we are starting a new practice with more or less data, more or less guidelines, and our colleges of physicians have not approved yet this practice. And we are also prescribing pills at the moment, knowing that most of the pills will be crushed and injected. So is that the right formulation? So the team where I work is a low-threshold OAT clinic, seeing more or less 230 persons in downtown Montreal, and we really felt we had to discuss these ethical issues together, and we had an ethical specialist who came with us, and people with lived experience, our patient in the clinic, in order to really have this conversation. And this is also a suggestion, if you want to start this new practice, it's a good idea to have this circle of conversation and discussion with the people and the users. And mostly I'm gonna ask questions. I don't pretend I have the answers, but I want to highlight also the ethical principles that are underlying all these questions. The first questions we have is, are we really reducing harm? Are we doing more good? Or can we sometimes, with this new practice, be in the maleficent? What harms could we be creating when we do that? Are we really increasing or assuring the security of our patient with that? Are we respecting the autonomy and the choice of our patient? And are we creating more transparency and trust? Or are there still issues of transparency and trust with this practice? And how can we enforce justice and equity? Who are we going to choose? Parenthesis to say that when I speak about a safer supply, I am not including IOT, injectable opioids, that we do have in our clinic. And then that's a debate, but let's say for the moment we're really more talking about the hydromorphone tablet. I don't see my time, so I feel I can speak like as much as I can. No, okay, you tell me when I'm done. So the first question we have to answer collectively, and again, the definition changed from one person to another. What is safer supply? And what is the objective? And if it's really a public health objective, if the objective is to replace and ideally completely what the person is buying on the unregulated market, are we really able to do that? And and if the objective is to prevent buying from the street and dying, are we really the best person to do that? And how can a bunch of black sheep doctors can really achieve this objective? How can we tolerate, as a team that was started and made to prescribe OAT and to be a treatment team, how can we tolerate the overlap of a public health objective and a treatment objective? We were used to treating people, to reaching goals, to pushing some of our patients to reach more goals and so on. How can we tolerate that the only goal would be you're still there and alive, and that's fine. You can continue using as much as you want, inject as much as you want, as long as you're alive and you're not buying from the street, that's fine for me. sounds easy when we say it like this, but we were brainwashed to as clinician, and that's normal. That's the way we were trained. So this is really a very conflicting objective. What do you say to someone who tells you, you know what, I'm going to lower my methadone dose now because you will prescribe me more hydromorphone, and I could inject more now that I feel safe. How do you tolerate that? Are you so calm with that and at ease with that? And are we responding to the real need? Are we really first prescribing enough to really replace the unregulated market? How do we cope with the fact that most of our patients would tell us, well, I will sell some either to buy Coke or to buy fentanyl or to buy food. How are we trying to use safer supply to, as a prescription against poverty? And then, is that the real tool for that? How do we ensure the security of everybody? Most of the clinicians who have been doing that have been very courageous. They are starting a new practice that's not existing. They fear sometimes they're going to lose their license when you prescribe 400 of Cadian plus 100 milligram of hydromorphone. If you feel a bit sweaty, you know, and how many of us will be really willing to do that? We're just a few bunch of us. But also the security of the person. So are we really sure that prescribing a very low hydromorphone dose is enough or is making something for security if the person still has to use fentanyl 3, 4, or 5 times? Or is she even in danger because her tolerance will change? When she has enough dilated, the tolerance lowers, and then at the end of the month, maybe she doesn't have anything and she needs to buy fentanyl and her tolerance is lower, so she cannot tolerate anymore. We don't know yet. What do we do about the potential diversion and resale? And that's a question we often have, or maybe this is what we want. Maybe we do want resale so that we can saturate the black market that's with something pharmaceutical. And that's one of the reasons why you should start now before the black market comes before you. But still, we were trained as clinicians, and we were shamed that we've prescribed too much, and that's because of us, that now we have an opioid problem. So we should not prescribe anymore. How do you tell GPs, okay, now that's finished, prescribe, but maybe not the chronic pain, but to these guys, yes, and then people get confused. What are you telling me? How can we really assure informed consent? How can you really consent? And that's what very well described in yesterday, patient choice on OAT. How can you really consent when you have no choice? This is the only molecule that you have. You are in withdrawal, and if it's not that, it's nothing, or it's the black market. Shouldn't we be giving access to the real substance instead of the dilated tablets? So for example, now we're discussing, should we prescribe vials with liquid hydromorphone at least? So we take away the crushing and the infectious risk partly. Would that be enough? What would happen with the preloaded syringe? Will we increase the risk in doing that, or the infectious Hep C transmission, or whatever? Or why don't we prescribe directly fentanyl? Who will do that? Will you allow people to come to have fentanyl IV in the community? So that are many questions. And we also have inequity and injustice. Who should we choose? We have limited access to treatment. And should we prioritize people with high dose hydromorphone or diacetylmorphine that need a nurse? The person has to come 3 times a day, 4 times a day. You have to be open during the weekend. Or should we prioritize treatment, or should we prioritize safer supply? How do we do that? So who do we choose in the context of limited resources? And I want to finish just saying that the elephant in the room is that we are talking about a very limited medical solution based on the shoulder of the few person to a public policy and a stigma crisis. So if the goal is really to overcome the black market, to diminish the overdose, we have to, safer supply is one step, and I am a true defender of implementing broader safer supply. But frankly, we have to speak about decriminalization, we have to speak about public policy if we really want to reach that goal. And now I want to finish by saying goodbye to Alexandra de Kiewit, one of my dear friend, passed away 10 days ago, sorry. She was, most of you know her. She's been the co-founder of CAPUD. She's been in INHSU, Asherai. She's been a drug activist, very involved. We've been giving classes to medical students together for 10 years now. She changed the way medical students see people who use drugs. So I wanted to say bye to her, and thanks to what she did to the community and especially for future medical students. Come and see us. We have 2 posters, and I want to underline also how much we don't use a lot 24 hours morphine. So I realized that slow-release oral morphine is an OAT option that is not used broadly in many countries. So for those of you who want to know more, come and see us at the poster, but also you can find our slow-release oral morphine guideline in French and English on our website. So thank you so much.
And we'll just hold questions to the end. I know I have all kinds of things I want to ask. So jot a note, think through. Love to hear from Alex. Take it away.
Yeah, there's nothing like a false start to really get you going, right? I'm going to talk pretty fast. There's a lot going to come at you, but I will send my slides and my presenter notes so you have everything that you need. I'm just going to click. I am required to say that I do have no conflicts of interest to declare. I'm also required to state that this initiative is funded by Health Canada's Substance Use and Addictions Program, also known as SUOP. The views and opinions expressed herein do not necessarily represent the views of Health Canada. There we go. So the quick and dirty of safer supply in Canada. Here we go. So welcome to Canada. This is our province. These are our provinces, our territories. At this time, we've counted 21 federally funded projects that are across the country. So the main reason that I'm actually, this is actually not the best map. You'll see that random like red dot up in Quebec there. It's actually down in Montreal. The reason I'm showing you this is to show you that most of the programs are actually in British Columbia and in Ontario. You'll see there's very, very few services for safer supply on the Atlantic region, as well as up in the northern regions. There's actually only one at this time operating in Whitehorse, Yukon. The good news, there is some. There are going to be more programs and services that are going to be announced in the coming months and years. I'm sure that will happen sooner or later. It's also really important to note here, however, that this map does not indicate local demedicalized compassion clubs or buyers co-ops that provide people with a safer supply of drugs through drug user groups and associations. So currently there are only 2 or 3 projects that Matt and myself are aware of that are actually doing this, or at least 2 that are only being public about doing it. It should be really clear to say that drug user groups and associations have basically been doing safer supply informally in their communities literally for decades. They are the experts in this, and so at the end I will just remind you to take their lead. So the quick and dirty on the research, what have we got? So there's currently about 30 studies taking place in Canada, just Canada alone that is. Sorry, let me just slide to my notes here. I do get asked a lot, like, where is the evidence? Like, where is the proof that this is actually saving lives? Well, folks, stop, don't go any further. I'm here to tell you that the evidence does exist. Safer supply is absolutely saving lives, and even more convincing research and evidence is being published every single week. Safer supply has certainly gained traction over the course of the past 2 years as one approach for addressing the drug poisoning crisis. There's a bunch of different mixed method studies. There's comparative analyses, qualitative, quantitative methods being used. There's also studies that are looking at health chart data, like administrative data and chart reviews. So comparative case studies, needs assessments, client outcomes. We're also really excited to say that we know that there are studies we haven't even heard of, particularly ones that aren't happening in our country. We're very excited because we're certain there's a plethora of publications coming in the coming months and years. So what is the evidence actually saying? Well, there's a substantial body of evidence on heroin-assisted treatment, so HAT or HAT, and opioid agonist treatment or therapy, OAT, that's certainly been built over the last 30 plus years. These are from programs in Canada, the UK, Europe, the rest of Europe, Australia, etc. Safer supply is certainly informed by this evidence, as well as evidence that comes from harm reduction services. Safer supply providers like Andrea and Marie-Ève they're pulling on existing clinical guidance for those programs, but they're also actually developing their own, which is just absolutely fantastic. This slide here is actually a sum up of a bunch of different quotes from an assessment that was done of the implementation of safer supply programs across the country. This was actually published this year. The reason I'm gonna leave these up here while I talk is because the theme here, it's not just about safer supply saving lives and preventing overdose, it's about enabling life. People are able to live their lives with safer supply. They are not having to work every day on the street to be able to get by and get well. They are able to go to a real job and do their thing. Not to say that if somebody wanted to hustle on the street, well, that's their business and they can do whatever they want. People who receive a safer supply, though, in a lot of these programs are reporting improvements in their health and their social well-being, increased access and engagement with health and social services. Of course, we are seeing reductions in overdose risk and fatal overdoses. We're seeing massive reductions in emergency visits and hospitalizations, reductions in fentanyl use and other street acquired drug use. And of course, I think with that piece also comes reductions in contact with police and having to resort to criminal activity to be able to get what you need. We're also seeing improved relationships with family members and loved ones, which I think is a huge piece that speaks to enabling you to live your life to its fullest. Of course, without a doubt, there's always significant challenges with programs like this. I mean, I think the first is likely obvious. These are only pilot projects. They're lacking guaranteed, robust, permanent funding and resources. Additionally, we know that there's an insufficient number of and types of programs, as the prescribers have alluded to. There's current program models that are just so time-consuming for participants coming to the pharmacy or the clinic 3 or 4 times a day. Also, staffing. It requires extensive staffing, and if you know anything of the current Canadian healthcare system, well, you know that it's in the shitter, and that we're having a shit hard time getting people into clinics, let alone an emergency room. We also know that current safer supply medications are simply not strong enough. There's a clear need for a wider range of types, formulations, strength. We need to be matching what folks are getting on the illicit market, because if we're not, then almost the intervention is partly futile because we just can't address that need. Of course, goes without saying, there's serious stigma and a lack of understanding around harm reduction in people who use drugs in a number of these services. We're also having a bit of a struggle with some of the more conventional or traditional addiction medicine communities that maybe just, I think, have a misunderstanding of what the actual goal of safer supply is. Safer supply is not to be seen as a bridge to OAT or recovery or abstinence-based models. Safer supply is really meant and dedicated to save people's lives and help them live their lives to the fullest. And so it's really just about engaging with prescribers in those conversations. We also hear, as Marie-Ève referred to, the concern around diversion. I can't tell you how many conversations I've had about diversion with prescribers, and I love it because I'm really, the concern, so for folks that don't know, that basically the prescribed medications that a prescriber is prescribing is not actually being consumed by the person they're prescribing to, and that they're being sold or exchanged for other goods or services. So I'm actually here to tell you it's a good thing. Diversion of safer supply medications actually extends the reach of safer supply medications into the street and actually helps us flood the market with like drugs that we know of what quantity and quality it is. We're actually seeing that this diversion of safer supply medications in the vast majority of circumstances is rooted in harm reduction. It's rooted in a mutual aid and community-based support in which people who use drugs are learning how to save themselves. I'm running out of time. Scaling up safer supply. So I think that this is a great slide for us in Canada, but also for you folks out there. I think we really need to push. The main thing is going beyond this medical model, right? So we need to move far beyond a prescribed model of safer supply. We need non-medical models, community-led compassion clubs or buyers clubs, decrim, a full decrim, not with like very low thresholds, but a full decrim, and a regulated drug supply. We need that all together to be able to provide people with a continuum of options for their own care. We also need to make sure that these funding options go past just a pilot project. We need funding that is not based on who's going to be the next person that's prime minister or the premier of the province or territory. We need to make sure that these programs are there and they're there to stay. We're as a community of practice more than happy to continue engaging with prescribers, not just in Canada, but across the world. Often I find that just having genuine, authentic conversations with people over a few months will make them much more confident and comfortable in their prescribing practice. I'd also be remiss to say we do need certainly many flexible models. A lot of Canada's population is centrally dense in a lot of the sort of city centers, but we do have many rural and remote communities that really need these models, but need them in a different way. And that also goes to say we also need models that address specific population needs and cultural needs, specifically in Black, Brown, and Indigenous, First Nations, Métis, and Inuit communities. With that, I'm just going to I'm going to steal 30 seconds. I'm going to plug our community of practice. So the sheet that I handed out to you, if you don't have one, come get one from Tommy somewhere there. Basically, it's got a bunch of resources. We're a community of practice that's a pan-Canadian community of practice. It's really our purpose to facilitate knowledge exchange and capacity building. We are interdisciplinary. We have over 1,000 members, and we've only been running for about a year now. That's members from across Canada, everything from nurse practitioners and physicians, people who use drugs, researchers, activists, policy folks. It's the whole gambit. We are taking additional members. This is your invitation. Please join us. Check out our website on that sheet, tons of resources, stuff around diversion, evidence for safer supply. We have a resource library that has over 900 journal articles. We've got webinars, upcoming events. We'd love to have you join us. I'll just pop this slide up, I guess, as the last one. The one thing I really just want to drive home is that safer supply is not a novel idea for people who use drugs. Like I said, they have been doing this for decades. So really now is the time to listen, to step back, and let them take the lead. Thank you.
Thank you so much, Alexandra. I'm really glad to introduce our last speaker. While we're changing PowerPoint. So our last speaker is Matthew Bounds. So Matthew is the program manager with the Canadian Association of People Who Use Drugs. He's also an international board member with International Network of Health and Hepatitis in Substance Users and a knowledge translator for the Dr. Peter Center. His freelance writing has appeared in publication including The Conversation, Katie, Doctors Nova Scotia, Policy Options, and The Coast. Matthew was also on the 64th Canadian delegation to the Commission on Narcotic Drugs. He is a current drug user and a formerly incarcerated person.
Thank you. And thank you to INHSU and my co-presenters for presenting for me. I feel like I don't really have to do much, but maybe hammer down a couple points. My presentation is moving safer supply forward, the need for decriminalization and demedicalized models of safe supply. And as you can see, the toxic drug supply doesn't just impact people who are living in poverty or whatnot. These are all celebrities that have died from fentanyl, cocaine, heroin, benzodiazepine, or a combination of both. So this really impacts all of us. So I do have a couple of declarations to declare. I have personal fees from AbbVie and grants and personal fees from Gilead Sciences. I also want to acknowledge I am someone who uses drugs. I have been on a safe supply, and I have been impacted by the criminalization of drug use. And I'd like to begin by acknowledging that where I work and where this presentation was created was in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which the Mi'kmaq and the Maliseet people first signed with the British Crown in 1725. We were all treaty people. So here's a couple photos just to demonstrate what our drug market does look like. These are all drugs that I have purchased on the Canadian market, either from someone I've known on the street or mainly from the dark web. And I have tested most of these substances and have seen things like xylazine and flurazepam, etolazam, carfentanil, fentanyl. For the most part, drug checking services in Canada are really like sporadic, but you can send them away. So usually if I take a little bit of a substance, say the red substance, for example, I was getting skin ulcers and infection-related injections, and I just knew something was up with it. It was a really strong batch. I just sent a little bit away, and it came back tested positive for xylazine. Anytime I would send it away, I would just put it in an envelope and write fuck off to the police. If you're searching this, it's just a little piece of dope. Don't do nothing with it. And it would go to a drug testing service in British Columbia, and you put your email and everything, and as soon as they test it, you get your results. So really, within 1 week, you're getting results of your drug tests. This is a range of drugs. As we can see, it's benzodiazepines. Some of these more concerning ones are these benzos that were being sold in Halifax that were actually sold on, it was etolazam liquid being put on candy tarts. So obviously this could be marketed to a population that we don't want to see using high doses of benzos. So, I couldn't really do this presentation without acknowledging that Kaput has been really leading the conversation with Safe Supply. They created the Safe Supply concept document in February 2019, and this Safe Supply concept document has been probably one of the most great literature cited documents in most academic safe supply documents. Usually people use this, use the definition of, our definition of safe supply. And I'm going to speak a little bit about kind of the nuance between safe versus safer supply. So there is this argument that, no drug is completely safe. And I think, we have to acknowledge that. But we have to also acknowledge that, we've been making safe sex compared to having safer sex for a long time. So we can have safer sex with some education, or we can have safe sex with a condom, and I think we can do the same with drug use. And drugs that are prescribed and regulated through a pharmacy are a lot safer than any unregulated toxic drug supply. So just think about that. If you have the power to prescribe a drug that's going to be picked up at a clinic and prescribed of known quality and quantity, you have to start doing that now, or you're going to see a saturation of unsafe drugs. Medical programs tend to use the word safer, but people who use drugs have been advocating for a safe supply and continue to advocate for all safe supply of drugs. Obviously, there's drugs like cocaine that kind of fall on the spectrum of medium risk use that we just don't have the pharmaceutical alternatives for. So I've been involved with some research around decriminalization and safe supply. My colleague, Dr. Tommy Brothers, and I were a part of a study in Halifax where we gave a safe supply of drugs and managed alcohol to people in COVID-19 isolation hotel shelters. And, the world didn't end. Everybody actually retained treatment and they stayed isolated. Not everybody, I think 4 people left and 2 of them came back, so really only 2 people left. It's just been incredible to kind of see the support that we've been seeing from younger doctors. to prescribe safe supply. So like, I've been getting safe supply from a physician in Halifax. I got an appointment on Wednesday of next week to potentially look at like a fentanyl prescription, which are, very progressive things and things we got to consider moving forward. I've done I've been involved in other research around decriminalization and safe supply, and I'll just move on. So I'm going to talk about 3 models of safe supply: heroin-assisted treatment, medical safe supply, and compassion clubs. And these are kind of what we have to work with now, but we got to continue to scale them up. And as Alex said, like, we need all of these versions until we, really get it and really kind of scale these up to reach the people that we can reach with these medications. It's not going to have the impact that we want it to. So here's a chart from Dr. John Marks, who pioneered heroin-assisted treatment. And on the left axis here, you got social and health harms, and with an unregulated criminal market that's high up there. Then on your drug policy spectrum on the right here, you got unrestricted access and an unregulated market, and again, a lot of social and health harms. And the 3 versions of safe supply that I'm talking about all fall under this strict regulation and control. So they're all falling under a version that is providing essentially like no harms. So we got to like look at this and like, if it's not causing harm to anybody, why aren't we doing this all over the world? Why aren't we doing this now? And I think, like, things do happen in Canada, things do happen in Vancouver and Ontario that do get spread across. But let's not like take the lead of fentanyl, let's take the lead of safe supply and really start to like just concentrate the drug market with safer drugs. So heroin-assisted treatment was created by Dr. John Marks, operational in various countries around the world, including Switzerland, the Netherlands, Germany, the United Kingdom, and Canada. There's an extensive peer-reviewed academic literature base for this. It's very medical, but it works for the target population. And the Crosstown Clinic operating out of Vancouver downtown, out of Vancouver's downtown east side. It has approximately 120 plus or minus patients. They prescribe their patients either liquid diacetylmorphine or liquid hydromorphine. People must come in 3 times a day for their dose. For a short period of time during COVID-19, they were offered take-home doses. And they also have to come in like at very strict times. So it's like at 7:30 till 8 a.m. There's like, they come in at like 7:30 to 7:40. They let 5 people in. They only get X amount of time to inject, and then they're moved along. This has been successful for the people that it works for, but it's very medical. And what's interesting, a lot of people actually don't inject their dose, they actually end up muscling their dose. And that's just a picture of the Crosstown Clinic on Vancouver's downtown east side. And medical safe supply, and this is exactly what Dr. Andrea Serrater was talking about. These are DILI 8s, D8s. I took this picture myself of a safe supply that I was prescribed. I was prescribed anywhere from like 10 to 15 DILI 8s, and then I would get like a long-acting hydromorphone on top of that. Most common medications include, I guess typically like even, hydromorphone dilaudid. Heroin is still a medical version of safe supply. Slow-release oral morphine, etc. There are various programs that offer powdered fentanyl, sufentanil, and fentanyl patches, and I'll be talking about those shortly. And these are all prescribed by a physician and picking up at a clinic or a pharmacy. So as I said, they are known quality and a known quantity, and they are a medicalized version of safe supply. But they are hard to receive take-home doses, and that can be restricted. It can have like a kind of effect of like being chained to a pharmacy or not just not having the freedom that you may have. In Victoria, there's a Safer initiative, and they've been prescribing various forms of fentanyl. This is a form that they did, so they had just kind of like looked at like what are some of the things that their safe supply is doing for people. So the right dose and the right drugs for me, safe, positive, and welcoming spaces, safer supply and other services are available, accessible to me. I'm treated with respect. I can easily get my safer supply. Helps me with function and improves my quality of life as defined by me. I think that's important to mention. So this is Dr. Christy Sutherland. She operates out of Vancouver's downtown east side. She has been prescribing powdered fentanyl. She has kind of two programs operating. One where it's prescribed through a prescription and it's all paid for, and one where you can actually go and pay for 1,000 microgram dose of fentanyl, and it's actually given in a tablet, and it's mixed with caffeine. So these are very progressive forms of safe supply that that are hitting Vancouver's downtown east side, that the market has completely been saturated with fentanyl and benzo-related analogs. So I think before we get anywhere else like that in Canada, we have to start looking at some of these models and scaling them up as soon as possible. And this is just another article. Dr. Christy Sutherland was quoted, "I want them to break up with their drug dealer." I think that's really interesting because it provides this form of just a trust between the physician and the drug user, that if you can go in and say, I'm using drugs and this is the drug that I'm using and I want to prescribe, I think you start to build a unique relationship. So patients will initially have to use the fentanyl through injection or snorting under the supervision of a Portland Hotel Society nurse. Once appropriate doses are established, they can begin to take capsules home daily in larger quantities from the pharmacy less frequently. So this is interesting because we're seeing this model that's a very progressive form of safe supply being a lot more patient-centered. And she was also quoted, "If I were doing this 100 years ago, I'd be prescribing opium tea." So that's just shown how our drug market has been overtaken with fentanyl. So compassion clubs. A compassion club is a club where people pool together to pool their money together to buy safe drugs for cheaper. They also test their drugs comprehensively through a full mass spectrometer test. Drugs become a lot cheaper when bought in bulk, and when they have their known quality and quantity, it reduces overdoses and other health-related risks. This is a document from the British Columbia Centre for Substance Use on heroin compassion clubs, and it's a really great document. I suggest you read it. I'm going to talk a little bit about the Drug User Liberation Front right now. It was mentioned yesterday what they're doing by Garth Mullins. So I was actually fortunate enough to receive a dose from them. I was in Vancouver for International Overdose Awareness Day in 2021, and I got a dose of heroin. And they're also evaluating this, which is really interesting. They have I think 20 or 30 people in their program, and they actually have they can go and buy drugs off the dark web at a very discounted price, and they're doing baseline interviews, 3-month interviews, and 6-month evaluation surveys. So I think these are things that are going to be based in evidence, and why not just start to follow the lead of the evidence now? So this is how they fulfill their center. This is how they get their drugs. They go to the dark web and they do market navigation. They usually have a few dealers that they work with. I know the people with the Drug User Liberation Front. I've talked with them. I've bought drugs from them and from the people that they buy from. But they have the tools and the techniques to do the quality control on site, and also package and label the drugs so people know exactly what they're getting. They know the quality, they know the quantity, and people, they haven't had overdoses. Not only have they not had overdose deaths, they had virtually no overdoses. So when people know what they're getting, they know how to use safely. So they do have like the eligibility criteria, and they do a little bit of an evaluation. Here are what the drugs come from, and they very much took it away from, like, they don't want these things to be in the hands of kids, so they, not for sale, keep away from children and pets. These are like 7 gram, there'd be 7 grams in each of these, and they'd be broken up into little cardboard boxes, and they're doing it with heroin, meth, and cocaine. So I'm going to speak a little bit about decriminalization now. So as some people may know, the Health Canada has allowed an exemption to decriminalize drugs in British Columbia from January 31st, 2023 to January 31st, 2026. And it's complete bullshit. Like, do not fall for this. It's just insane. Actually, I have to say, like, the day that this was released, there's actually a bill on the table by the NDP government, so the opposition government, to decriminalize drugs on a wide scale, on a national scale, and the bill could have easily been swung and voted and passed. But instead, the Liberal government said, no, we're not going to do this, and we're going to just give it to BC and see how they deal with it, like they do with a lot of things. And they whipped this exemption up so poorly that the scope of the exemption doesn't include drugs like benzodiazepines. As we know from the talk yesterday, the whole market on BC is benzos, so it doesn't have benzos in the drugs. They actually spell MDMA wrong. They spell MDA, which is a completely different drug. So they just didn't do their they didn't do their fucking job. And I think, it's really important to note that they set a low threshold at 2.5 grams. So it just means that this exemption is going to criminalize a different population of people who use drugs. And it's only for 3 years, and there's certain conditions. So there's just all kinds of criminal elements weaved right into it. So the Canadian Association of People Who Use Drugs have sued the Canadian government over the war on drugs. We did file a lawsuit against Health Canada. And it's interesting because we received funding from Health Canada, so now we can't talk to them about decriminalization. So it's just been this like elephant in the room. But like they acknowledge that, this is something that we need, but like they won't do it. But we just work with very low-level people. This is us filing the lawsuit on Overdose Awareness Day 2021. So I think, and I'll be wrapping up here, my time's coming up, but the status quo right now is the criminalization of drug use. So, and if you support that, you have to support organized crime, cartels, murder, the toxic drug supply. That's where all the financial support of the criminalized drug market is going right now. And the next steps of regulation, so we need to use community-based organizations to control the drug market. There's no need to commercialize a drug market that profits every time from somebody uses drugs. We don't have to use marketing to upsell drugs, like we can do this through community-based organizations. Medical safe supply forces doctors to control and police prescription drugs. The more we can move away from this, the better. You don't go to your doctor for a bottle of wine, so why would you for a line of cocaine? And a couple of take-home messages. All safe supply models are needed until we have a regulated safe supply. Don't wait for any more research before prescribing safe supply. We need alternative options for all modes of consumption. We're seeing a lot more people die from overdose deaths from smoking drugs now, which has been a new trend. And safe supply should match the current unregulated drug supply. For example, there is the safe supply of prescription benzodiazepines that aren't being used. And as I acknowledged all the celebrities that died before, these are all just a few of my friends that I've lost, including Alexandra, who Marie Goyev mentioned earlier. But this has been impacting me my whole life, and you know, this is something that we have to get ahead of now, or everybody's going to experience an intense amount of trauma and pain. Thank you.
We have 15 minutes for questions. Are there people who want to jump up to the microphones at all to ask any questions? Comments? People are slowly sauntering the way over there. Hi.
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 My name is Rose Schmidt, and I'm from the University of Toronto. I want to start by saying thank you to everyone on the panel today. It was really, really great, really wonderful to listen to. I was hoping, Andrea, you'd be able to talk a little bit more about why D8s are what we use in Canada, and also maybe a little bit about sort of the options for carries and things like that. So sort of logistics
Sure.
stuff.
Yeah. So we actually chose D8s kind of, you know, as the only thing available. But probably about 5, maybe 6 years ago, there was some local research in London, Ontario, because at the time we actually had an epidemic of infective endocarditis. And our local drug market at the time was primarily hydromorphcontin, which is the long-acting preparation of the hydromorphone, the D8s that we use for safer supply. And so, working with the infectious disease HIV doctors in London, we were actually able to show that hydromorphcontin was causing infections because of the beads and the cellulose matrix and the way people were using, which is usually, you know, using washes or reusing their filters to achieve more drugs from their original hit. Part of that study, they also compared the hydromorphcontin infectious risk to hydromorphone, so the immediate release version, and they found that hydromorphone was no more infectious than sterile water when they were doing these experiments. So we went, okay, well, this is kind of the best choice with the limited evidence that we have available, and so we started using hydromorphone. And you know, all public drug formularies, they like the cheapest option, so they asked us to use a generic. We did that, but very quickly, drug users told us that the generic hydromorphone does not cook down as well as the brand name dilaudid 8 milligram tablet. So when you cook a generic hydromorphone, there's a lot of silt, there's a lot of residue that's left in the cooker, and so those are called excipients, and they're going to increase people's risk of infection. And this was compared to the brand name dilaudid 8 milligram tablets, the D8s, that actually cook to a clear liquid. So again, on the, you know, the expertise of drug users, we moved forward to use the brand name D8s. This was also reinforced during the pandemic. There was a national shortage in Canada on the brand name D8s, of course. So we were forced to use the generics for a number of months. And when we were forced to go back to the generics, we started seeing quite a bit more skin infections, skin reactions that took a very long time to heal. I still have a small handful of patients that 2 years later were still working on their skin ulcers from the generics. So that, again, reinforced what drug users told us, that the brand name was a better choice.
And maybe if I can just add on that, I think we also we did a bit of inference with the studies that we had on heroin and then Salome, which showed non-inferiority of IV hydromorphone if you're going to do IOT. These studies were done with much higher dose, but that was kind of a compromise, and then BC had started for people who would come regularly 3 times a day, they would have IOT, but if they wouldn't, they could have hydromorphone tablets. So we kind of got influenced also by that, and that's a bit of the literature that we had when we started the programs.
Next question.
I had a comment and one question. For the comment, just if people are diverting, you should tell your patients if they present to the hospital to tell us what you're actually taking to avoid us overdosing you, which does certainly happen. I've seen it happen. And my question is, do you think it would be politically more acceptable to the people who oppose this if it wasn't free? Like if there was some daily cost to them, like there's a daily cost to wine, which is legal, like there's a daily cost to, you know, legal marijuana now, would it be politically more acceptable if there was some cost, way below, like you'd still crush the black market, but if they were, you know, instead of $100 a day, if they were paying like $5 a day for their safer supply, would that speak better to the politicians?
I'll jump in on that, and I will accept that argument if poverty becomes unacceptable to our governments and to the people who either support or don't support safer supply. I know that's not what you're saying, but that's always my rebuttal.
This is the foot in the door. This is the
Yeah,
foot in the door.
absolutely.
It's not necessarily right, but it's going to be better than $100 to $200 a day doing criminal activity.
Yeah. Yeah, but what we do say is, you know, and certainly in Vancouver, for Christy Sutherland's fentanyl substitution program, they do charge market cost. And so people will get the clean fentanyl product from her clinic at the same cost that they would pay for street fentanyl. So, you know, on equipoise, that's better, right? You're getting clean for the same price. But it's the nature of classism and stigma that, you know, people living in poverty, people living in homelessness are wildly overrepresented in the population of people who use drugs. And I think some of our critics say, well, it's not because of the drugs, it's because they don't have to pay for them and then they pay for other things. And I'm like, but yeah, who cares? Who cares? We've driven people into such marginalized situations that they're living like this. And so I don't think we have a moral leg to stand on with that economic argument at that point, because yes, people do have more money, and if they can now afford an apartment and food, I don't think we should charge. Because we do see with Christy Sutherland's, people don't improve economically so they can improve other, you know, parts of their well-being.
Hi, David Perlman, New York. Thank you for the wonderful presentations. Could someone speak about any experience or thoughts about more amphetamine safer supply, whether by prescribed or some other route?
Does anyone want to take that up at all? Matthew, do you have any thoughts about amphetamine?
I think there is a safer supply of methamphetamine right now. If you look at like Ritalin or Dexedrine, there's a widely acceptable and used version, so why not just give it to people? Because right now people are forced to cook crystal meth, right? So I think if we can just give them this, say, here, crush it up, sniff it, inject it, do whatever you do. I think there is a little bit of risk, as there would be with the bees, because a lot of times they are slower acting, longer acting medications, but they are available. I don't think the uptake has been really there with the stimulant safe supply like it has been with opioids, and that's an issue. But you know, I think people aren't dying from stimulant overdoses; they're dying from opioids and benzos.
And Matt, you might be able to, you know, highlight this more. We do try to prescribe stimulant safer supply in London, and people just, there isn't the uptake. The pharmaceutical versions that we have just don't hit what people need us to hit with the available options. We push the doses pretty far, pretty high, and people still don't feel like they're getting what they need. So I think there needs to be a lot more research and trial and error. I don't know if Matt, if you can say more about that.
Yeah, I would say it's got a lot to do with the mode of consumption. A lot of people are smoking crack cocaine, smoking meth. So if you give them like slow reacting beads, it's not as easy to do that. So they're going to go back to what they prefer and what they enjoy. And as Andrea said, like, it's not that people haven't done this. Like, people have been trying to do this. It's just the uptake hasn't been there. But like we do, like there is pharmaceutical grade cocaine as well. So why not like open that door too?
Yeah, and I'll just add to that. I mean, I think a lot of the advocacy we do is we've noticed that stimulants are only really being offered in a handful of clinics, one of them being Andrea's, like across the country. And so it's a huge gap, and maybe that's also why the uptake just isn't there, because as the same as we're seeing with the opiates that are being prescribed, it's just the dosages, the formulations, the types, the strength, they're just not there. And so a lot of our advocacy work right now is to actually shift the language from, instead of just saying safer opioid supply, to just saying safer supply, safe supply, and really making sure that all types of drugs are included in that. That includes stimulants. I would very much say to anybody in the room that's a program manager or considering starting a program, to really like make your program founded on that. That it's like all different types of drugs and formulations that we need. We're not just talking about opioids.
Thank you. Next over here.
Hi, Sarah Catacuzzi from the United States. So mind blown on the presentations. If you have any thoughts or comments about barriers you've received from pharmacists, both from the patient end and from the provider end, and then the equivalent of our DEA, the Canadian regulatory bodies, how you were able to, if that's an ongoing thing, work this out with them.
Who wants to jump in around this question?
I'm twisting my tongue, you don't see it, but yeah, so for pharmacists, in a certain way, it was easier at the beginning when we were starting patient than OAT, because they're so used to these molecules in chronic pain, for example. So they were used to it, they recognized it. But then, frankly, at some point, when the dose increased, then that's where it got maybe a bit more complicated. But to tell the truth, as I was saying in Quebec, most of the pharmacists who were involved were already, or the patient they were serving were already on OAT. But we did have, so I don't know if you've seen, but we did have to produce material around it. And this is about always, how do you start a new practice? So you need to inform people, you need to explain, you need to reassure. And also to acknowledge that our pharmacists were trained around control. And this is completely wrong. And we, even for OAT, there's no point, and there's nobody who's being controlled as people who are served with OAT. But again, when you start something new, you go with your champion, they talk to their friends, and then you produce knowledge translation material, and then and we invited them also to our discussion so they could ask their question and build knowledge. For our colleges, what we did, and again, I strongly suggest that even it could be difficult, and we had a lot of openness in Quebec though, we used the COVID period to start to increase and to build on this practice. So that was helpful. COVID has allowed us many things that we were asking for years. But also, and that's why BC was so useful to us, when you have like a clinical guidelines, you have clinical tools, you have training, you have everything. I think the colleges are more open because they see that there's a framework around it. So that would be my suggestion, but we were always very open. Very, we're going to do that. It's not a question. We're going to do that. Here's how we're going to do. Here's all the material. Would you rubber stamp it? No? Okay, but you know we're doing it. And we're still trying. That's the next step to us in Quebec. We're asking them to officially endorse this practice so that we can democratize it.
And I'd just add, like, I would say from pharmacists, like, you go in there and you've typically been on OAT or other medications, and all of a sudden you want like 20 milligrams or 20 Dilaudid 8s, and they just look at you like, what are you, fucking crazy? Like, I'm going to call your doctor, and then they call and they're like, well, yeah, that's what we're doing, and it's just like, they're just stubborn about it. They just, at the end of the day, they'll do it, but there's a lot of stigma and discrimination there.
I'll just jump in. I have a comment and a funny story. In London, actually, pharmacists were some of our earliest fans, so to speak, because it's a daily dispense program for the most part. And so if I see someone once a week or twice a week, the pharmacist is seeing people every single day. And so I think they actually have eyes on people's stabilization in a way that the rest of us don't. And so at least in London, it wasn't very hard to get pharmacists on board. We don't have a DEA in Canada, not really. One of the weirdest moments in my career is about 2 years ago, our clinic, we had a call with the White House and the Homeland Security and the DEA. And we don't really know why. They just kind of wanted to hear what we were doing. And so we did our dog and pony show, and we did our presentation. At the end of it, they're just like, well, all right then. And that's my best attempt at an American accent. And like the call was over. Yeah. And I haven't tried to use my passport in America since then, so we'll see.
Thank you.
Can we get another question here? I know our time is running out.
Sure. Brian Coleman from Vancouver.
Thank
I've been
you.
working in the downtown east side for 22 years. The last 2 years have broken my heart. Okay, we prescribe large amounts of Cadian, gram quantities, dilaudid. I was called in for my requisite meeting with the college, was able to collegially explain things. And our team, we do this. And however, we are partners with the individual that is sitting before me asking for a prescription. Okay? There's many more things in their lives than drug use. There's many more things that I can do, hopefully, than to correctly write a prescription. Yes. And the deal we have is you get everything. So I look at the fact that you're just on basic welfare, and the system will probably give you $1,400 instead of $600 a month, which will open options for you. By the way, you have hepatitis C, it's easy to cure. You keep getting abscesses, let's talk about that. Your housing sucks, I will help you with housing. So you have to engage. If you engage fully, then we have a partnership. So I am not a scribe, I am not a secretary, and I've used that line on people. This is not a McDonald's, my friend. Sit down, we're having a chat. And I've used Matt's line a few times about the system doesn't buy people alcohol. So if it just gets down to, you just write me my drugs and I'll be out of here. I hear you give safe supply, just write it and I'll be out of the office. The system doesn't pay for alcohol. If this is what it's reduced to, the solution is ultimately going to be the compassion clubs. It's going to be available, it's going to be safe, and it's going to crowd out everything else. But I think the piece that there's two things that kind of, that I haven't heard enough of is, one, this is a partnership. This is much more than about a prescription. It's about establishing a relationship so that we can improve each other's lives. We're serving you, we're together in this, and ultimately, the solution is going to go the way of alcohol, to my mind, and we're in crisis mode now. We need to react to the crisis, and I don't see myself prescribing 1.5 grams of Cadian to a bunch of people forever and ever. I'll do it for a while we're in crisis to save lives, because we need to do this, but it can't be the long-term solution.
Thank you. Sophia?
Thank
Last
you
question.
all. So just on this question of why the uptake of stimulant safe supply is maybe lagging, and particularly for Alex and Matt, I'm wondering if you think that the stigma that people who use stimulants experience is different to the stigma that people who exclusively use opioids. And I know in Vancouver, at least, there's been a lot of media attention to these so-called random stranger attacks, and the media hyperbole is that it's people who are psychotic and that it's because of stimulant drug use. And it seems, I think, probably to be driving a particular type of stigma. And so, yeah, is that, you're nodding, so, so what can we do about that? And, you know, what next for stimulant safe supply?
Can I take the first part, Matt?
Go ahead.
Okay. So definitely, I mean, I think you're absolutely right. A lot in the media, what we're kind of seeing reports of is like violent attacks, person smoked meth like 30 minutes before. And like, there's a lot of this really like rampant, terribly done journalism that just like really like leaks into like the way that the public will just like eat it up. So I think kind of like the first answer to the question, I'm sure Matt has more, is like actively talk to journalists or like people that you know that work in that field to try to change their language and their discourse around that. Like talk more about the conditions of poverty and like social determinants of health that like are pushing people to like have to like hustle to like make some buck. Yeah. Yeah, makes you do all sorts of funny things, right? Yeah. Matt?
Well, you know, I think right now we see there's a large, safe, pure opioids or pure cocaine supply in Canada for the most part. So I think like most people, like when I was growing up, it was cut cocaine, it was shit, nobody wanted it. Now it's a little bit pricier, it's everywhere, but it's pure. So I would say there's a huge kind of compassion club that's already happening, and I would say like, why put this into a medicalized model when it's already being done on the streets as it is? So let's continue to do that.
Thank you. Well, everyone, this has been a wonderful opportunity to dive into this topic. Thank you so much for staying, and if you have any other questions, we'll be here for a little while. Take care. Infectious Diseases Center, VIDC, and